Dr. Mama showed you this North American perspective, which Dominic Angiolillo led, which I think was a good summary of the data and its implications for care. And it actually aligns very nicely with the European guidelines. And he showed you this table, which shows the default strategy being for patients with atrial fibrillation and a coronary stent being triple therapy for a brief period of time, peri-PCI, and then the double therapy, using the word double to differentiate it from dual antiplatelet therapy. So double means an anticoagulant and one antiplatelet agent for 1 year, and then an oral anticoagulant alone. And then that can be modified to either shorter periods of more intense antithrombotic therapy for those at high bleeding risk, or longer periods for those at high thrombotic risk. And some of the key summary points is this peri-PCI. What do we mean by that? And what we mean is something between hospital discharge, which is day 3 to 5 after the PCI, generally for patients with ACS, or out to 1 month post-PCI. That's what we mean by peri-PCI. I'll get back to that. But I think that what my personal opinion is that for the average patient, the best time to stop the aspirin is about day 7 after the stent. We don't know exactly. There's a trade-off when we make that decision. So for oral anticoagulation, prefer a NOAC over a vitamin K antagonist. Clopidogrel is the P2Y12 antagonist for which we have the most data, and it's got a little bit less bleeding, so it makes sense to use clopidogrel. Could you use ticagrelor for patients at low bleeding risk and high thrombotic risk? It might be reasonable. And then stop the antiplatelet therapy at the end of 1 year for patients who have stable coronary disease. There's a lot that we talk about assessing bleeding and thrombotic risk. Most of us in practice, I don't think, use the scores and the complicated algorithms. They may be more important for clinical trials. But I think the two most important thrombotic risk criteria are: did the patient have an acute coronary syndrome, and did they have prior stent thrombosis? And those are two factors that would really make me consider longer-term antiplatelet therapy. And then for bleeding, the three criteria that seem to differentiate higher bleeding risk without so much higher thrombotic risk are prior bleeding, low hemoglobin, and older age. So those are just, I think, some of the highlights on the bleeding and thrombotic risk. We have the 4 main trials that have tested different antithrombotic strategies for patients with AFib and either ACS or PCI, and a network meta-analysis led by Renato Lopez summarizes this by, I think, what's clear even from the individual trials, and that is you have a substantial reduction in bleeding by using a DOAC and a P2Y12 and a short duration of aspirin and then stopping the aspirin, compared to vitamin K antagonist, aspirin, and clopidogrel. And there's no price to be paid in terms of the overall thrombotic risk. And Dr. Mamas went over the Augustus trial. I'll just reiterate that this was a factorial trial, so it compared apixaban versus vitamin K antagonist and aspirin versus placebo. It's the only trial that had a placebo comparator for aspirin. So I think that does make it the most important with respect to the aspirin issue. For apixaban versus vitamin K antagonist, one of the remarkable findings was in the Aristotle trial, there was a 31% lower rate of major bleeding with apixaban versus warfarin. Exactly the same in Augustus. So this kind of reinforces the fact that apixaban is the NOAC, the DOAC, that has the best safety data compared to compared to vitamin K antagonist. And then the aspirin versus placebo, this really reinforces in a rigorous double-blind fashion that when you add aspirin to other antithrombotic therapy, it is not safe. There's a doubling in bleeding, in major bleeding, in intracranial hemorrhage. So we only want to use it when we have really good data that it's reducing thrombotic risk. And so the most important analysis, I think, from Augustus with respect to this was one that John Alexander led. And he looked at the first 30 days and then after 30 days with respect to aspirin, whether aspirin was being used in addition to the anticoagulant and the DOAC, and then with respect to bleeding and thrombotic events. And what you see for the first 30 days, there's a trade-off. There's clearly more bleeding, but there's also less thrombotic events with aspirin, including less stent thrombosis during those first 30 days. But there's a trade-off there. I think it's about the same. You get about as much risk as benefit. So that's why there's some discretion. And that's why it's important. If you have somebody you're really worried about thrombosis, it's reasonable to continue. But then with respect to after 30 days, there's no question here. There's simply more bleeding risk and no antithrombotic benefit. So that's why don't go beyond 30 days. And then Dr. Mamas has showed you the results of the FIRE trial. This was a Japanese trial looking at 2,200 patients who had stable coronary disease and AFib, were on rivaroxaban, and either had single antiplatelet therapy used or not. And not surprisingly, there was less bleeding, about 50% less bleeding, without using the antiplatelet therapy. But what was surprising is there was also less thrombotic events, including less mortality. Now, this is a modest-sized trial. It may be an overestimate of the harm of continuing antiplatelet therapy. But I think this trial, on top of lots of other data, has convinced me for almost all patients with stable coronary disease, don't use aspirin in addition to an anticoagulant. That's actually really important. So then this was the summary then of what I wanted to go over. Generally, in this population, use clopidogrel as your P2Y12 antagonist, use aspirin for around a week and out to 30 days, and use DOAC alone after 1 year. Thanks for your attention.